Welcome back, everyone. Welcome back to a panel session. I will ask Dr. Kreider if you could please open the panel session and coordinate it.
Thank you, speakers. Did a great job and learned a lot. And so we want to open this up for questions from the audience. And so please go ahead with the first question. Good.
So our first question is for Dr. Abby Smith-Ryan. In physically active women during the lateral phase, we can apply training protocol with a higher volume of strength training with higher doses of creatine, 5 grams a day. And during the follicular phase, use training protocols with a higher volume of endurance training with lower doses of creatine, 3 grams a day. Is it true?
Can you hear me? Looks like there's a delay. Okay. I have not heard why you might change the dosing. So, I think there could be an application of doing a creatine loading phase, potentially in the luteal phase, to allow for greater saturation to help with that higher volume and potential performance differences. Otherwise, I would say a daily 5-gram dose would be sufficient. It will just take longer. So I wouldn't suggest a need to change the dosing throughout the menstrual cycle.
Thank you very much for your response. Another question is actually, Dr. Abby, again for you. And it's what could be the relationship of hormonal contraceptives and creatine supplementation?
I don't know if we know the impact yet, but I do think it's an important question. I think a lot of, or the most common form of contraception in the US is a monophasic birth control, which follows a similar path to what I showed with similar increases in estrogen. So I would anticipate a similar response as we would see in a normal eumenoric cycle. However, I'm not sure, particularly with something more like an IUD that provides a localized hormone. So I don't think we know, but I would suggest we could still see similar potentials based on those physiological differences I presented.
Thank you very much for your response. Our another question is for Dr. Kylie Harmon. Very interesting to visualize the level of evidence of creatine in medical rehabilitation. According to your experience, if you had to choose 3 groups of patients who should take creatine in the process, which people would it be?
A good question. I really do think that as we kind of accrue more evidence of in these different pathologies, I think probably every patient population can benefit from creatine in some way. Based, kind of on the bulk of the literature that we saw in that review, muscular dystrophy patients can really benefit from it. I think it needs to be explored further in immobilization, but it's likely very beneficial. Of course, recovery from exercise. It's hard to pick just 3. I really think that there's been so much research presented over the last 2 days that creatine is just beneficial for pretty much everyone. So even if we're not seeing specific observable improvements in some of these patient populations, I don't think that means they're not occurring. We might just not be measuring the correct parameters. We might not be, getting the dosage or the timeline completely correct for these patients.
Thank you very much for your response. Our another question is for Dr. Kendo. Could you please speculate on the mechanism behind the reduced keratin in the lower limb versus upper limb? Are you aware of any studies directly comparing upper versus lower body muscles in response to supplementation? would be any rationale for that?
Well, thanks for the question. And I agree with Dr. Rawson. With exercise and creatine natural synthesis, we probably are unsure right now. But my guess is with an older adult, we may see more preferential benefits in the lower limbs because it's kind of overcoming the natural process of aging. If we do have type 2 muscle fiber loss substantially in the lower limbs, that may see some greater beneficial effects. There's one study I'm aware of, Dr. Brad Schonefeld was part of this, where they looked at regional differences in creatine efficacy in upper versus lower body. And I believe the lower or upper body was more affected by creatine. That was in a younger population. But again, I really try to stress the emphasis in the lower limbs, primarily for older adults, for decreasing the risk of falls and fractures. Obviously, Bruno's group is the world's leading group that has looked at this from a clinical aspect. And for functionality, this could be applicable. So it could have something to do with muscle morphology or the activity level of the individual.
Can I add a little bit of that too? Initially, a lot of studies looked at upper versus lower body strength. I don't think you can just make a interpretation of efficacy by looking at one part of the body. You have to also consider what the familiarity is of the exercise test being done. So for example, I'll go back to the 90s when we did our studies in football players. Everybody does bench press. That's something that you consistently see upper body improvement. There's more variability in technique and squat and cleans and all those type of things. And so when you interpret the literature, you know, I had never seen a study showing that my shoulder has more creatine retention than my leg muscle versus calf muscle. You know, you might see a little bit due to fiber differentiation, but generally it's going to be about a 20 to 30% increase, depending on what you start with. But there may be differences in performance based on the familiarity and the variability in the actual tests that you apply or do as a researcher. Anybody else have other thoughts about that?
Thank you so much. Thank you so much for your response. Our another question is, it has been highlighted that GAA, this is related to the previous question, has several ways to enter different cells. How does GAA prefer brain and would not enter into the muscle? It's for all speakers, please.
I'll start. GAA is really interesting as a precursor. There is some studies that Serge Ostajic, who will be speaking to us, I think, on Saturday, has done and showed that smaller amounts of GAA in the amount of about 3 grams per day can increase brain creatine content a little bit even more effective than creatine monohydrate. And I think that's some fascinating research that we just now need to keep on doing that work and then expanding it. But what's interesting is, and I think Eric mentioned this, it doesn't seem to affect the muscle as much. It seems to be better for the brain. And then I think there are also potentially some other nutrients you might also be able to enhance uptake a little bit in the brain. So this is an area of a new frontier in creatine research is how can we really increase the brain creatine content? If we know it has some benefits on cognition and reducing insults from injury and all these type of things, finding ways to maximize that and finding dose-related studies are really the next thing that needs to be done with that literature. Others have comments about that?
Rick, I would just agree with everything you've said, and it really highlights the fact that if you're conducting research on the brain as if it's the same as skeletal muscle tissue, you're going to be led astray. Skeletal muscle is designed to take up creatine, and the brain seems designed to resist external creatine. So we have to be very thoughtful about how to increase brain creatine levels and some of these other compounds that might bypass the transporter problems. And GAA seems to be the promising compound in terms of brain health. But there's just so much work to do in this area.
So
Well,
if you
I've
don't
got
have
some
any other
questions.
comments,
So
okay.
let's talk about prudence. Eric talked about it's prudent maybe to know with the known effects of creatine monohydrate supplementation on everything from reducing potential for injuries in the brain and recovery and rehabilitation, and the known safety profile and effectiveness in a lot of clinical trials. Is it something that for preventive rehabilitation or preventive, but potentially reducing the insults of injury and ischemia in the brain and the body? Are we at the point where it's prudent to just recommend that people take 3 grams of creatine monohydrate per day?
I can start. Yes. For high-risk individuals, for those at high risk for a mild traumatic brain injury, yes. I think you summed it up. We have an inexpensive, widely available nutrient, a dietary supplement with an excellent safety profile and known muscular benefits. If you're at a high risk for a mild traumatic brain injury, which causes creatine depletion, yes, it's more prudent to suggest that those athletes, or maybe in the case of military or certain occupations, those individuals use creatine. I think the real departure here in the world of nutrition is kind of from a big historical picture, is that nutrition seems to have been largely built upon eradicating deficiency diseases. And we've done that for 100 years, but now we're at a point where we're looking at increasing the amounts of certain nutrients to promote optimal health, even if they're non-essential. And then I think that's where a small daily dose of creatine fits in for older adults, those at high risk for brain injuries, and multiple other populations. But certainly, if you're at high risk for a brain injury, I can't think of a downside. And I will say that in the States, I've spoken to some sports dietitians who are in charge of collision sports, like football sports dietitians. And this is a real concern. And this is a decision they're ready to make, that their players who are at high risk for concussions or have had previous head injuries should be prophylactically taking creatine for the reason of brain health, in addition to the muscular performance. So
we made a similar conclusion in our 2017 creatine position stand. You look at the safety data, you look at the animal data, you look at it, put it all together. It's like it's almost malpractice not to let an athlete take creatine that could benefit them from training, adaptation, and if it does provide some reduction of risk. We know it increases the speed of recovery for injuries. If you look at the injuries of creatine user versus non-users in that data set in all types of sports, they get back to playing faster. And if you look at some of the spinal cord injury data, I think the prophylactic makes a lot more sense than waiting till the injury and then start giving them a bunch of creatine, because you could benefit from a whole host of things. So we come into that a lot in the discussion about whether we should recommend or we should not recommend, but the body of evidence on creatine is so strong. It just makes sense from lots of areas to help reduce the risk of people that are involved. I mean, everything from soccer to football to battle, you can get concussion, military. It just makes some sense. I think it is a prudent thing. Do any other panelists have any comments? How about Kylie or Bruno?
Oh, I'd like to ask you guys, mostly Rick and Eric, if you are aware of any longitudinal randomized controlled trial trying to test this hypothesis, because it seems to be very difficult to anticipate the number of concussions. So you need to supplement a large number of athletes in order to expect a reasonable number of events to test the hypothesis. So this is the main difficulty in this field, or you guys envisage other limitations in studies in this area? Because it's strange for me that we don't have any studies in this area, because the rationale seems to be strong enough.
I'm just going to jump in. So I didn't tell this to Bruno before, but there's a group here in Canada and it's planned for the fall to our CIHR, which is similar to NIH. So the goal is to randomize 300 athletes on creatine or placebo before they get a concussion. And then there's a prevalence of about 15% in our Canadian university sport. Then we're going to measure the rate of recovery with TMS. We have a whole bunch of ways to see if it can. We're working on that now. It's interesting you brought it up. It's been in the works. Dr. Chilibek's going to be leading it. It's a multifactorial institution sport. Dr. Scott Forbes will be part of it. So I'll probably be tapping most of you guys on the shoulder, but it's hard because the thought is, do we give creatine to individuals susceptible to head trauma before, or do you give it as soon as they suffer a concussion? We're aiming before, because if it takes so long, as Eric talked about, to get in the brain's going to be healing already. So what if we'll look at two facets. Can creatine increase aspects of brain health in the healthy brain? And then for those who get trauma, can it speed up recovery? So we'll see what the Canadian government thinks, but that's the area. I think we've all talked about this in the last decade. How do we can't hit people over the head with a hammer and stuff like that. So unfortunately, people get concussions, but it has implications for children, car accidents, UFC, boxing, pretty much everybody. So that's our big push here, and hopefully we'll get funding, but it costs a lot of money to run these studies. And we're going to touch on Serge over in Norway now with his brain creatine content analysis and stuff. So stay tuned, hopefully, and we'll have more information. Maybe for the next creatine conference, we'll have it.
So we've been talking about that as well in the United States. A lot of the universities now are having MRI or MRS spectroscopy before, as people come in as freshmen, and then can quantify if they get injury, how the degree of injury. For example, University of Nebraska, right next to the training facility, strength conditioning facility, they have a MRI, MRS system, and they test everybody. And so what we've been trying to do is identify where those places are, where we might be able to put a network of universities together and do this type of thing, where you have players who do take creatine or don't, and then you have enough N size to be able to really make some estimations of whether there's a prophylactic benefit or a treatment benefit. But that takes very large scale studies, because even in the United States and American football, only 5 to 10% will get a concussion a particular year. So you have to have, dozens of schools and hundreds of athletes to be able to get the N size to be able to make a statistical comparison. But these are some of the challenges. But I completely agree with Eric and others and Bruno, these are the studies that need to be done. And the rationales there, the animal data is supportive, the safety profiles there, and the cognitive benefits. There's lots of reasons why it could, but it needs to be done in a large scale study like that. So maybe we can talk Canadian and NIH and others to do that, but that's what's going to take to answer that question.
Rick, I think the other problem will be that all these athletes probably already take creatine. So it's going to be difficult to find a good placebo group.
Absolutely. Absolutely.
I think,
okay.
Rick, can I make one more comment?
Please.
This is incredibly expensive and very difficult work to do, a randomized controlled trial for concussion. And we're really not even discussing some of the more difficult parts. We're talking about the sample size, but the type of brain injury, the location of the brain injury, some individuals seem to be such outliers in terms of the effects of a concussion. Some people return in days, some people it takes months. In some sports, hiding the fact that you had a brain injury is a real issue, because you won't be allowed to return to play. So I think in the meantime, I think we can do some excellent work with some really well done case studies, and also just to kind of jump off some of the great work that Mike Greenwood did on injuries and muscle dysfunction, just to simply track athletes very well and compare those who voluntarily took creatine to those who voluntarily did not take creatine, and look at the prevalence of injury and the time course of recovery. And I think those data probably exist in a lot of athletic training rooms around the country. So there's work we can do between now and whenever Darren finishes his gigantic 10-year concussion study. Thanks, Rick.
Excellent. Excellent point. Thank you.
Thank you very much. Questions. One for Dr. Bruno. How is the relationship between creatine supplementation and glycosylated hemoglobin explained, considering variables such as exercise and diet, please?
Well, that's difficult to explain in the context of our trial. Of course, it's a human trial, and you try to map out some potential mechanism from clinical data to molecular data. But I do believe that in this specific trial, exercise training enhanced, actually creatine supplementation enhanced the effects of exercise training on insulin sensitivity, and these ultimately lead to a reduction in glycated hemoglobin. So I think exercise training mediated such effect. From a molecular point of view, I believe this occurred because of an increase in GLUT4 translocation and also in AMPK expression. So these two molecules could explain the beneficial effects of this co-intervention, exercise training and creatine supplementation.
Thank you very much. And our very last question is for Dr. Abby Smith-Ryan, and that is, you have published some interesting information regarding creatine and caffeine supplementation. What are your thoughts in the light of current literature? Is it recommended, or should we avoid mixing these supplements?
Thanks for that question. Many other people here have also published data on that. The consensus from when we published some data about 4 years ago is if you want the full benefits of creatine, it's not going to be as effective with high doses of caffeine. I would say they are both very good. And so if you want your caffeine, just not super, high doses will impact the effects of, or could impact the effects of creatine. So I say mix ahead. Go ahead and enjoy the both worlds.
Yeah, I have to add something to that as well. When we talked about this with Roger Harris years ago, I think it was a 2010 or even the 2004 meeting, and it would come out about caffeine and maybe counteracting some of the creatine effect. He says, you know, Richard, we mixed creatine and hot tea and things when we did all our initial studies. So I don't think there's probably much to it. You got to remember, though, caffeine has ergogenic benefit and creatine has some ergogenic benefit, and they may be synergistic, but they may also hide some of the benefits mutually. So we don't ever tell people not to have caffeine, because that would go against almost all the initial studies that mixed it in hot tea that was done.
Well, amazing discussion. Thank you so much to all of you. Do we have some of us like any questions, or can
Let me just thank everybody for the panel. I do want to give a shout out to Kylie Harmon, Dr. Jeff Stout, I know a proud PhD advisor right now. You did a super job doing your presentation earlier. I just wanted to point that out. So if there's other universities looking for assistant professors coming down the road, I'm sorry, I didn't have muted. So what I'm saying is, I wanted to give a shout out to Kylie and to Dr. Jeff Stout. who's got to be proud because he was the mentor for Abby as well as Kylie. And Kylie, this is a PhD student, did a super job presenting. One that's like, wow, she is really good. And if there's other faculty members, chairpersons like out there, they're looking for faculty, Kylie did a super job. So thank you very much.
Thank you for that. I appreciate
As well as
that.
everybody. So thank you for, we'll be back tomorrow.
Thank you so much, everyone. We deeply appreciate all your knowledge. We have learned so much from you. And like Dr. Kreider said, we will be looking forward to seeing you tomorrow. I will just very briefly introduce the topics, which are the role of creatine in the development and activation of immune responses, creatine in T-cell anti-tumor immunity and cancer therapy, role of creatine in the heart, health disease, the potential role of creatine in vascular health, and creatine supplementation for patients with inflammatory bowel disease, a scientific rationale for a clinical trial. Thank you one more time to all of you, and we'll be looking forward to seeing you tomorrow.
Bye.
Here.
Thank
Bye.
you.